Today I'll present a large employer's intervention to implement tiered physician networks and health plans, and what we learned about what happened based on observations of patient choices made through analysis of claims data. So this work was a collaboration with my colleague Meredith Rosenthal, and I want to acknowledge our grateful receipt of funding from the HCFO initiative at the Robert Wood Johnson Foundation for this work. So in terms of just a roadmap quickly for today, I'll talk a little bit about the networks themselves and then spend some time describing the Massachusetts Group Insurance Commission's Tiered Network Initiative, which is the setting that we evaluated, and then turn to the findings, what we observed, and finally conclude with some of the policy implications from the study. So, a lot of this was covered very well by Dana in her talk just now, so I just want to highlight again here that this evaluation is looking at tiered provider networks, so these are distinct from narrow networks, and the idea here is for health plans to use managed care network design to try to channel patients to a preferred set of providers while maintaining their choice still, so that again all the providers are included in the network, and patients receive a quality signal, which is that patients or providers are tiered based on performance on quality metrics and efficiency, and also a financial incentive to choose a preferred provider, which is that in the case of physicians, they pay a lower copayment at the time of the visit than if they see a non-preferred provider. I'll refer to preferred providers also as Tier 1 providers. That's how they were named in the initiative that I studied. The middle tier, Tier 2, are average performers, and then finally the non-preferred providers were placed into a Tier 3. And so the idea is not only that there'll be an effect on patients, but that providers too will have an incentive as a result of this type of network design to change their own behavior in response to a loss of market share or the threat of a loss of market share that's associated with being in a non-preferred tier. Now turning to review how tiered networks affect patient incentives, essentially the idea is that the tiering aligns a patient's incentive to have high quality and high value care with their financial incentive to pay less out of pocket for their own care. The information about quality and value provided through a tier ranking could be useful to a patient, although it depends on their perception of the validity of the information and how it's presented, and also whether it provides new information. So do consumers trust the information on the quality that's coming from this particular source, and how does it help them based on what they already know? In terms of the literature, the evidence on patient response to quality information is mixed, and while patients are known to rely on recommendations from friends and family more frequently than formal sources of quality information, in part because they can be difficult to understand and use, there are studies that find evidence of changes in market share towards higher rated providers when rankings provide new information about provider quality. So when you think about the effect through the financial incentive, we have a lot of evidence that patients respond to higher prices in terms of cost sharing, and they switch away from care when it's more expensive to them. And in particular, in the case of prescription drugs, patients switch away when their own drugs get moved to higher and more expensive tiers, either to lower priced alternatives or they cut back on their care. But I think it's no surprise here to realize that physicians are very different than prescription drugs, and physicians aren't really considered to be interchangeable like drugs are, and the importance of trust between patient and physician suggests that copayment differences could be less effective to induce patient switching. There is early evidence that suggests consumer response to tiering in cases where the price difference across tiers is large. However, some of our own work on patients in Massachusetts who are in the plans that we're going to study on their awareness, found low levels of awareness and use of the physician tiering, and this is also likely to affect our results. So turning now to the Massachusetts Group Insurance Commission's initiative. The Group Insurance Commission is a quasi-independent state agency in Massachusetts that's tasked with providing and administering health benefits to state employees, also employees of several local municipalities, and retirees and their dependents. And so currently there are over 400,000 lives enrolled in the GIC health plans. About 10 years ago, the GIC launched this initiative to create a database that could be used to construct tiered networks. And to do so, they worked with all 6 of their non-Medicare health plans and had the plans pool their entire books of business to maximize sample size and eliminate potentially confusing and conflicting measurement, and develop a database of physician performance at the individual physician level on cost efficiency and quality. The cost efficiency measures were case mix adjusted episode treatment, grouper evaluation of efficiency, and the quality measures were largely HEDIS-like claims-based process measures. So once this database was developed, the GIC gave it to their health plans and directed them to design a 3-tiered tiered physician network where physicians, very similar to the framework that Dana just presented, physicians were evaluated on quality first, and they needed to meet a quality bar in order to be placed into the top tier. And then if they also had low cost or a high cost efficiency, they would be placed in Tier 1. Average performers on cost were placed into Tier 2. This is also where physicians for whom there was not enough data were placed, and then the lowest performers were placed into Tier 3. The copayment differences across the tiers were for office visits and ranged from about $10 to $15 if you saw one of the preferred doctors, and went up by about $10 for each tier, so that about $25 for the middle tier and $35 at the top tier. Or I'm sorry, the bottom performing tier, the most expensive. When we looked at which types of physicians were included in these plans' tiered networks, the plans really focused on specialists, all 5 of the participating plans. We had to drop one of our 6 plans from our analysis due to small sample size and incomplete data. So in the 5 plans that we looked at, all 5 tiered these 6 specialties listed across the top of this slide. And then plans had flexibility to tier additional specialties, many of whom did. Some also chose to tier PCPs or internal medicine physicians, but many did not. And then while the GIC suggested that plans allocate about 20% of physicians into a top tier, 65 into the middle, and 15 into the bottom, you can see here that the actual networks constructed by the plans varied a little bit here. In particular, Plan 1 had a very large Tier 1, whereas Plan 5 put really the vast majority of physicians into their middle tier. So we were interested to the effect of tier rankings on patient choices, and in particular whether we could observe whether a physician's tier ranking has an impact on a physician's market share of new patients versus whether there's any impact on the percent of a physician's patients who switch to see somebody else. We think these are different decisions that a patient makes, and tiering could have differential effects depending on which situation a patient is in. So for the first, on a physician's market share of new patient visits, what we did is we looked at all patients who had never seen a physician of a certain specialist type, nor had anyone in their family, and looked at the decisions that that group of patients made. And for the second analysis, for existing physician loyalty analysis, we looked at patients who had a relationship with a physician. So this is a patient who had at least 2 prior visits with a particular physician in the claims data in the prior 2 years, and then also returned to see a physician of the same specialist type once the tiered networks were implemented. And so among that group, the group of patients who was going back for another visit, we looked from a physician's perspective how many patients returned to see their existing physician versus how many switched away, and whether that varied by the existing physician's tiered ranking. So turning to the results, for the new patient visits, at the top of this chart, it shows you the predicted market share based on our analysis for doctors who had a top tier ranking versus an average tier ranking versus being in the bottom tier. And there's no difference for the top 2 categories, but those in the bottom tier had a predicted lower predicted market share of new patient visits than did their peers. While this number, 0.5, is very small, and there's a pretty small difference than in terms of the numerical value from the numbers above, 0.57, this is because we're measuring an individual physician's market share of the total pool of new patients in the GIC. And so for some specialists in a year, this was 800 or 900 patients. So while any one physician gets a very small number of these patients, when you compare the difference between a 0.5% of market share versus 0.57, it's actually a significant, meaningful difference from the physician's perspective. It's a difference of about 11% in terms of their own, in terms of the share of their share, essentially. It's a little confusing. I apologize. Looking at the specialists here, the second group of rows, we analyzed just specialist physicians. So we left out doctors who might be considered by a patient to be their usual physician. So internal medicine physicians, OBGYNs, and pediatricians, and again saw a similar pattern where physicians in the bottom tier had a lower market share of new patients than their peers. In contrast, among those usual care physicians, we found no effect, that there seemed to be no differential across physicians. And then turning to the question of whether there's any impact on patient decisions to switch away, we found the answer there to be no. We observed no effect of a physician's tier ranking on whether his or her patients returned for another visit or switched away. And this was also the case when we looked at specialists versus usual care physicians. So quickly, I want to reiterate that this is early evidence. This is in the first 2 years where this intervention was up and running, and so I think long-run implications will be important to evaluate to see whether these results change as patients learn more about the network design and become more familiar. I think it's also important that we study the impact of tiering on patient choices in other contexts, and in particular when hospitals are tiers. It sounds like the Blue Cross initiative will be out soon, so we'll learn something there. And also when there's a much larger financial penalty for patients depending on their choices across physicians than that was studied here, which was just a $10 to $20. So in conclusion, in contrast to what we observed among choice of prescription drugs, we do observe significant loyalty from patients to their physicians that they've seen previously. And also, I think interesting, we observe here that the impact of tiering on choices seems to be moving people away from the lowest performers as opposed to necessarily moving people from average up to the best performers. In terms of takeaways and implications, I think this makes sense. You know, from a patient's perspective, it may be that the type of information, the quality signal, and the financial incentive is more powerful when people are choosing to see a new doctor, which is more easy to trade off between seeing another new doctor, as opposed to switching away from somebody who you already know and have a relationship with and already have a set of impressions about. I also think that choice of health plan and provider is really complicated, and so while this evidence suggests tiered networks can be one element of this process, that education and other tools are going to be really important as we continue to try to understand how we can move market share towards higher value providers. And then lastly, I just want to highlight that the capacity constraints may also be important here, in which I mean by that is that at some point the top and most preferred providers are going to have full panels. It's going to be hard for patients to continue to move, in which case the provider response to these incentives is going to be pretty important. If providers themselves respond by improving their performance, then we could still benefit even if patients are limited by capacity in moving themselves. So thank you so much. That's what I've prepared for today, and I'm happy to take questions at the end.